Hi guys, welcome to week 14, talking about the GI system medications. So let's go ahead and get started. First thing I wanted to mention is that anorexiants are medications that suppress appetite or change the metabolic pathways. In order to use these and be successful, you should combine this with lifestyle changes, including to include some long-term weight reduction overall, or to obtain that. Drugs for weight loss are becoming more effective, and there's some potential serious side effects, but side effects are becoming less and less frequent, and really can tweak these for the patient to make sure they're on an appropriate medication. Each case is different, so patients will need close follow-up with each of these medications. Some of the example meds are those listed on the right-hand side of the screen here. Most prescription weight loss drugs work by making you feel less hungry or fuller. Some do both. The exception is Oralist that's on there. It affects the way your body absorbs fat. So education of clients is essential. Basically should not take over-the-counter or herbal medications without notifying the healthcare provider while they're on any of these medications. Some may require multi-dose vitamin or multivitamin daily to suppress or to supplement the essential nutrients that perhaps they're not receiving depending on what type of diet they may be on. Prescription weight loss drugs that you can use for more than 12 weeks are what we call long-term use drugs. And these can lead to really major weight loss compared to inactive treatments that doesn't use medicine or placebos, basically. So the combination of weight loss medication as well as lifestyle changes really leads to a greater weight loss than lifestyle changes alone. And taking these drugs for a year or more can actually mean a total body weight loss of up to 12%. That's more than with lifestyle changes alone. And it may not seem like a lot to lose up to 12%, but losing, even 5 to 10% of your total body weight and keeping it off can have really important health benefits. So examples, lowered blood pressure, lowered blood sugar levels, levels of fats in the bloods or triglycerides that we've talked about in previous units. So lots of potential health benefits that can come with weight loss. So next we'll talk about some of the drugs for bowel disorders and a few other GI conditions, but we're really going to focus on your lower digestive tract, constipation, diarrhea, irritable bowel syndrome, inflammatory bowel disease, nausea, vomiting, and also pancreatitis we'll touch on. So constipation is really just defined as infrequent passage of hard, small stools. If the stool stays in the colon for too long, then too much water will be reabsorbed, causing hard stools. So it's usually a symptom of some underlying disorder. Common condition, multiple reasons for this, but could include dehydration, decreased movement, surgery, anesthesia. It basically puts the bowel to sleep. Medications can do it, including our opioids or narcotics. So on the other end of the spectrum, we have laxative therapies for bowel evacuation. Really want to make sure if we're considering these medications, we want to assess the abdomen, looking for distension and what are the bowel sounds like. You want to look and talk about the patient's normal bowel patterns. Peristalsis needs to be restored prior to laxative therapy. So if the bowel's not working, then giving the laxative will do no good. You want to assess for risks like colon cancer, esophageal obstructions, intestinal obstructions, fecal impaction, any undiagnosed abdominal pain. This can be very generic in nature, and abdominal pain could mean lots of things. And if someone gives a laxative while you have an obstruction, then the colon pressure will increase, and this could cause a bowel perforation, which is really serious. If diarrhea occurs while the patient's taking laxatives, we want to counsel them to discontinue that because it can lead to electrolyte imbalances and then dehydration. We want to use this in caution in pregnancy and lactating women. Usually want to take with a glass or two of water. Think of this as helping to wash out the gunk out of the plumbing or trying to get the stool to go down the toilet. Without any water in the toilet, it's pretty impossible, right? You do also want to assess the client's ability to swallow, assess for diarrhea or cramping, and assess for and educate the client about proper use and not to overuse laxatives, because we do see this in some disorders as well. And the bowels can become dependent on laxatives and stop working without them. So another reason not to overuse them. So some of the types of laxatives. We have our bulk forming agents with absorbed water, adding size to fecal mass so it can activate the stretch receptors in the bowel, and then this allows for passage. You do want to make sure patients remember to drink plenty of fluids, as water will be pulled from the body and put into the colon for evacuation. So we want to make sure they have enough fluids on board. Our saline cathartics or osmotic laxatives are not absorbed in the intestine. They pull water back from the fecal mass to create more watery stool. Our stimulants are kind of irritants. They irritate the bowel to increase peristalsis, and these stimulants are what cause the abdominal cramping and can cause dependence in order to have a bowel movement also. And then we have our stool softeners or surfactants. These cause more water and fat to be absorbed into the stools. They're usually used for prevention. Herbal agents and natural products available over the counter. There are many of these. And then some miscellaneous oil agents could include like mineral oil as well. So here are just some of the examples of those. I'll let you read through those. And there's a few more. All right, so next, moving on to diarrhea. This is basically an increased frequency and fluidity of bowel movements. It occurs when the colon fails to reabsorb enough water. It's a type of body defense mechanism, actually. But if prolonged, it can lead to fluid or electrolyte and acid-base imbalances, which could cause systemic effects to occur. And we do want to monitor the frequency. How often are these occurring? Treatment of diarrhea really depends on the severity and the etiology. So what's causing it? And we want to treat the underlying cause. Opioids can actually be given for severe diarrhea because, again, as we stated before, opioids can cause some constipation. So it would make sense to that you can use them for this, actually. So some of the therapies we can do, we do want to assess fluid and electrolyte status. Like I said, that's very important. Look for any blood in the stool or ask your patient about any blood in the stool. You don't want to use these if constipation should be avoided. And you want to assess the client's ability to get out of the bed safely. If they're an older adult, will they be able to go to the bathroom quickly? Make sure they have a bedside commode or they're close to the bathroom. This can be, high indication for falls and maybe actually contraindicated in some clients as well. So some of our medications for simple diarrhea, like I said, we do have opioids that we can use. However, these are different than the opioids we use for pain. So notice the two that we have listed there. And then there's lots of miscellaneous agents as well. Pepto-Bismol is one of them. Probiotic supplements, so lactobacillus. This helps to increase the normal flora in the human gut and decrease the diarrhea. Commonly used for patients taking antibiotics, or at least they used to be. Actually, the new studies are showing that they don't really work. So it used to be when we'd have patients who were prescribed antibiotics, especially on multiple antibiotics, we would also be prescribing a probiotic supplement or recommending that they take a probiotic supplement to prevent things like C. diff. But over time, our studies have begun showing that it doesn't hurt probably, but it's not helping in the same aspect that we were hoping it would. So you'll see that used a little bit less. IBS or irritable bowel or spastic colon or mucus colitis. Symptoms include abdominal pain, bloating, excessive gas, kind of some colicky cramping. And it can be alternating constipation and diarrhea with mucus in the stool. We do encourage patients with this to keep a food diary and see really what are their trigger foods. Common trigger foods are things like caffeine and wheat, lactose, or foods that can cause bloating. Don't really have a prototype drug for this condition and only includes drugs and symptomatic treatment. Again, that food diary for patients with IBS is super important. This is different than inflammatory bowel disease, but ulcerative colitis and Crohn's is something you may run across and you should know a little bit about. Just very briefly here, ulcerative colitis is a mucosal erosions in the large intestine, whereas Crohn's is ulcers in the distal portion of the small intestine. Can have some environmental triggers, smoking, NSAID, stress, can cause some inflammatory bowel disease, and symptoms range from mild to acute depending on the patient's status. You can also go in between periods of remissions and exacerbations as well. So then treatment of IBD. Treatment is ever changing and it's really a specialized source of medicine, but medications from several classifications, and they're always changing. So again, it's pretty hard to keep up with this, but some of our mild to moderate cases, we can use this 5 ASA agents. If that's not successful, they often will add on an oral corticosteroid. And if that attempt fails, then sometimes an immunosuppressant is even needed. Vomiting or emesis. It's a defense mechanism, right? It's used in the body to rid itself of a toxic substance. It's controlled by the vomiting center in the brain, or can be, associated with lots and lots of different conditions, and many drugs can cause nausea and vomiting as side effects. So treatments of nausea and vomiting can include many things. You know, we have many over-the-counter drugs and herbal options that are available, and I think our book does a reasonable job, if I recall, on discussing this. Some serious nausea is treated with prescription medications. We want to assess symptoms that precipitated the vomiting and treat really the underlying cause. Of course, pregnancy can be the underlying cause, right? And then it's a little harder to treat, but if sedation and continued vomiting occur, sometimes an NG tube with suction may be needed to suction out the stomach contents and eliminate whatever is causing this. High safety concern for clients, can become drowsy, want to assess for fall risk, immediately report any vomiting of blood. And we don't typically use over-the-counter antiemetics for long periods of times, because then we're only treating a symptom and we're not actually treating the cause. So we want to make sure our patients get full workups of what is causing this. Again, lots of medications. I'll let you read through just a few of these that are available. And of course, they all have pros and cons, and they all have patients that we should not be using these in. Nausea and vomiting in pregnancy or during pregnancy can be like super debilitating, and it often requires treatment. Unfortunately, many medications are limited in pregnancy, just like in everything else, due to either known risk to the baby or even the unknown risk to the baby. Studies are limited, just like everything else in pregnancy. All of our treatment options can be limited because it's not very ethical to perform studies on pregnant women. So, unknown cause, but there's a high positive relationship between high levels of HCG, or that human gonadotropin, and increasing severity of nausea and vomiting. Ginger has been proven to be more effective than placebo and kind of equivalent to vitamin B6. Peppermint tea is common. That can certainly be effective too if your patient likes that. And see chapter 35, actually on page 1042, there's a section that discusses pharmacological therapies for nausea and vomiting of pregnancy and gives some more specific treatment options that are available. So make sure you look over that. Here's some of our other antiemetics that can be used. Again, risks, pros and cons to all of these. There's risk with all of them. They are certainly very helpful in the right context and in the right patient. So you just want to be careful. Ondansetron or Zofran is pretty commonly used. Doesn't have the same sedative effect of some of the others, but it is QTC prolonging. So if your patient has a prolonged QTC, and you'd see that on an EKG reading, that would be a drug you'd want to avoid with them. Other drugs going in the opposite directions, drugs to actually stimulate emesis. These are typically only used in emergency situations. So I'll just cover this briefly here, because I don't think this is ever going to be something you'd be giving out in practice as a midwife. Hopefully not, but I do want you to make sure you are aware of these actually. They're used only when the client is alert, because there is a risk for aspiration. And if the client is comatose, then we do like a gastric lavage. So that's that tube that's placed in the stomach and attached to suction to empty the gastric contents. But some poisons and caustic chemicals should not be vomited back up because they're caustic. If they're caustic going down, they're going to be caustic coming back up, and they can cause twice as much damage. We can do activated charcoal as well, or that Ipex syrup that's listed there at the bottom. Next, let's talk about pancreatitis. So pancreatic enzymes, we have our amylase and lipase. These become trapped in the pancreas, and they're not allowed to be released into the duodenum. They then escape into the surrounding tissue, and this causes inflammation. And anytime there's inflammation, it can certainly cause pain. And the pain of pancreatitis is actually quite severe. So it's associated with gallstones in women, alcoholism in men, although it certainly can be alcoholism in either group, but this is typically what we see. And gallstones can be the cause in either group as well. Pharmacotherapy, we have replacement enzymes, we have supportive drugs for reduction of pain and gastric acid secretion. Oftentimes when patients with pancreatitis get admitted to the hospital, they're kept NPO, or they're not allowed to eat or drink anything. They're given pain medications, and sometimes even an NG tube may be needed to decompress the stomach. And definitely some antiemetics, because oftentimes these patients will have vomiting to go along with this. So our pancreatic enzyme replacements, the pancreas secretes essential digestive enzymes. Lipase and amylase and nuclease require presence of bile in order to be able to work. And the lack of secretion results in malabsorption disorder. So replacement therapy can certainly be needed. Here is this creon that's listed up top. This contains lipase and protease and amylase of pork origin. It will aid in facilitate the conversion of lipids into glycerol and fatty acids. It also helps to convert starches into dextrin and sugars and converts proteins into peptides. These all aid in the digestive process when your pancreas can't do it for itself. This can be used as replacement therapy for clients with insufficient pancreatic exocrine secretions, and the patient may also receive opioid analgesics for pain control or IV therapy or insulin because the pancreas isn't secreting appropriately. And then antiemetics, of course, if they have nausea and vomiting going on. All right, so the digestive system. We're going to be covering the digestive system. We'll talk about peptic ulcer disease, talk about GERD or gastroesophageal reflux disease, and drugs for treating peptic ulcer disease. So the parietal cells secrete hydrochloric acid. These are used in the control of acid secretion. This helps breaks down food, it activates pepsinogen, it kills microbes and secretes intrinsic factor, which is used for the absorption of vitamin B12. There's a thick mucus layer and bicarbonate ions that neutralize the acid in the stomach, so it doesn't break down the lining of the stomach or eat a hole in the stomach. We have peptic ulcer disease. This occurs due to a gastric ulcer or a duodenal ulcer. An ulcer is really just an erosion of the mucosal layer in the GI tract. So gastric ulcers are lesions in the stomach. Duodenal ulcers are lesions in the small intestine. Both of these are under the broad term of peptic ulcer disease process. Risk factors, there's lots, but you'll see them listed here. Symptoms of peptic ulcer disease. Well, again, peptic ulcer disease is really an umbrella term. It covers gastric and duodenal ulcers. Oftentimes, patients will have a gnawing or burning sensation. It's below the breastbone in the soft part of the abdomen. A change in appetite with weight gain, or they may have weight loss. They may have nausea and vomiting, frequent burping or bloating. More severe symptoms include a sharp, sudden, persistent stomach pain, bloody or black stools, depending on how high up or how low the ulcer is in the system. Could have some bloody vomiting or vomit that looks like coffee ground emesis, again, depending on where that ulcer is. And next, we're going to discuss the types of peptic ulcers to include the duodenal and gastric ones. So duodenal ulcers, they're in the intestine, and they're more common than gastric ulcers. They occur usually in the 30 to 50-year-old age group. Usual symptom, again, that gnawing or burning in the upper abdomen. Pain's worse when the stomach is empty, and it goes away after they ate food. So if your patient tells you they have pain in the stomach every time, and then they're hungry and they eat something, and then all of a sudden the pain goes away, that kind of should alert you to, hey, maybe this is a duodenal ulcer. Bleeding can happen. It can be bright red blood with emesis or dark tarry stools, and often H. pylori or Heliobacter pylori is related to this. A little different than our gastric ulcers. Gastric ulcers are in the stomach. They're less common type of ulcer. The pain is relieved by food, but may continue after it too. And it's more common in women over the age of 60. Remissions are infrequent or absent, more commonly associated with cancers, or certainly can be, and often associated with overuse of NSAIDs or frequent use of NSAIDs. So some of our causes, again, peptic ulcer disease are really that umbrella, but Heliobacter pylori, this is the primary cause of peptic ulcers. It's a gram-negative bacterium that ends up taking over in the GI system. Other causes or contributors to ulcers and inflammation can be secretion of excess gastric acid, the hyposecretion of adequate mucus, and NSAIDs, again, including ibuprofen, aspirin, things like that. That's the second most common cause. Again, most common peptic ulcer disease is H. pylori, second is NSAIDs. So let's kind of cover what H. pylori is here briefly. Kind of a picture showing what this is, but it's really a tiny acid-resistant organism, a germ, a bacteria, if you will. Normally, the acid breaks down and eats any bacteria that enters the stomach, but H. pylori is super resistant to the acid, and it can survive and actually thrive in the stomach. It produces an ammonia-like chemical, which then neutralizes acid in the immediate vicinity, and it protects itself from that stomach acid. So that's kind of how H. pylori works and why it's such a nasty, nasty disease. couple of different ways to diagnose it. You can do a blood test. We look for the antibodies. We can do a breath test, and we measure the labeled carbon dioxide. And we can also do endoscopy. So that's the scope that goes inside the stomach. Biopsy sample of cells can be obtained from the stomach lining and examined further. Treatment, well, goals of treatment are really going to be, primary treatment is that we completely eradicate it. Ulcers allowed to heal, and then they go into remission. But there's a very high reoccurrence rate when H. pylori is not fully eradicated, so infection can remain active for life if not treated appropriately. Antibiotics are really the treatment of choice, and there's multiple ones needed because otherwise H. pylori can become resistant. So usually multiple antibiotics are prescribed along with H2 blockers or proton pump inhibitors are used in combination to eradicate it. All right, so next we'll just briefly mention, I think I covered this pretty well already, but NSAIDs and peptic ulcer disease. NSAIDs really interfere with the stomach's ability to protect itself from acidic stomach juices. And the stomach's three defense mechanisms against these are that it's got the mucus that coats the stomach lining and it shields it from the acid. It's got a chemical bicarbonate that helps neutralize that acid, and then the blood circulation to the stomach lining that aids in the renewal and repair process. But all three of these can be affected by the overuse or misuse of NSAIDs, again, including aspirin and ibuprofen-like drugs. So treatment of peptic ulcer disease includes a combination of pharmacotherapy as well as lifestyle changes. Those are very beneficial. So lifestyle changes include eliminating tobacco, alcohol, reducing stress, avoiding certain foods and beverages like carbonated beverages or spicy foods. Treatment goals are really to eliminate H. pylori, promote ulcer healing, and prevent reoccurrence. And again, some of our drugs, antacids, antibiotics, H2 blockers, and proton pump inhibitors or PPIs. GERD is gastroesophageal reflux disease. It's caused by a loosening of the sphincter between esophagus and the stomach. That's the cardiac sphincter. And acidic stomach contents basically move up into the esophagus, and that leads to that heartburn or burning feeling that patients will experience. And it can also lead to esophageal ulcers or esophagitis or strictures even. So treatment is pretty much the same or very similar to peptic ulcer disease. Primary goal is to reduce that gastric acid secretion. And since GERD is associated with obesity, losing weight and some lifestyle changes can certainly be very helpful and necessary. But interventions for symptomatic relief include elevating the head of the bed, avoid fatty foods or acidic foods, eat smaller meals more frequently, quit smoking, no alcohol use. Again, PPIs, H2 blockers, antacids can be helpful. And for some, surgery may be necessary if pharmacological or lifestyle changes or those in combination don't work or aren't effective enough. Again, just to cover those drugs used for peptic ulcer disease and GERD, I won't go into those in more detail because I think we've already talked about those plenty. But PPIs really work to block the enzyme hydrogen potassium. That's the ATPase, which are responsible for the secretion of a hydrochloric acid or HCl. You can take these with antacids. They're used short-term therapy for peptic ulcer disease and GERD. More effective than H2 blockers, generally speaking, because these help to reduce gastric acid secretion. And you're really inhibiting that proton pump from secreting the acid into the stomach in the first place. They do work a little longer or have a longer duration than the H2 blockers, but they can take 3 to 5 days for it to actually become effective at reducing pain. And that being said, they can also continue working for 3 to 5 days even after they've been stopped. Do want to counsel patients to take these 30 minutes prior to eating, usually before breakfast, so it has a chance to kick in and work. And stop that acid secretion before the food is ingested in the body. And the body naturally wants to secrete that acid to help break down the food. So that's why we take it 30 minutes before eating. Here's an example of some of our PPIs or proton pump inhibitors. Notice that they all end in prazole, P-R-A-Z-O-L-E. Side effects are usually GI related, except for the increased risk of osteoporosis related to the interference of calcium absorption. So we prefer our patients not to take these long term. H2 blockers, then kind of similar, but these slow the acid secretion in the stomach, and they do this by blocking H2 receptors. So remember, we briefly mentioned this earlier in talking about antihistamines and allergies. So H1 affects our nasal passages related to allergies, and H2 then affects the GI system. So I remember this by thinking when I'm doing a head-to-toe assessment on a patient, H1, I'm going to start, at the nose and upper allergy area, and H2 is going to go down into the stomach. It's just how I remember it. But often these H2 blockers can be the drug of choice for treating peptic ulcer disease and also GERD. Don't want to take antacids at the same time as H2 receptor blockers, as it decreases the absorption of the medication. And the way I remember these is by thinking iodine. I-D-I-N-E is the ending for these H2 receptor blockers. There were other drugs that were in these class 2, including ranitidine and cimetidine. Some of these were removed from the market due to too much NMDA, which can be a cancer-causing agent. But famotidine, nitazidine, many of the others are still on the market and still being used effectively. Antacids then. Antacids are inexpensive. They can be pretty effective at neutralizing stomach acid. They work in about 10 to 15 minutes, but they don't last very long, usually only a couple hours of relief. And they relieve symptoms, but they don't promote ulcer healing. So they may, if you have heartburn, these may be the quick drug that you go to for temporary relief, but they won't last very long. But simethicone can be added to help reduce gas in combination with these. Your aluminum compounds and calcium may cause constipation. Magnesium compounds can cause diarrhea. One way that I remember this, I guess, is Al, or Al for aluminum. I just say Al is always constipated, and Maggie, or magnesium, dines out and gets diarrhea. So that's how I remember it. I don't know what works for you or what works for your brain, but those are kind of the ways, some of the ways that I remember which one will cause constipation and which one will cause diarrhea. Antacids then, here's some examples of those, including our Tums or milk of magnesium, or Alka-Seltzer, the sodium bicarbonate anyways. Antibiotics anyways, these are just some of the ones to treat H. pylori infections in the GI tract. Usually, again, 2 or more antibiotics because they increase the overall effectiveness and reduce our risk for resistance, thus bettering our chances of actually curing the infection. And then, of course, our PPIs, H2 blockers or the PPIs. And then some of these bismuth compounds can be used also. Even though it isn't an antibacterial, it inhibits bacterial growth and can prevent the H. pylori from adhering to the gastric mucosa. And then lastly, just some of our miscellaneous drugs. Several additional drugs are benefiting in treating peptic ulcer disease, including sucralfate or carafate. Really helps to coat the ulcer and protects it from further erosion. It's kind of like putting the ulcer in a bubble so it can heal. Misoprostol or Cytotec inhibits acid and stimulates production of mucus. It's also used to induce labor in the OB departments. And then metoclopramide or Reglan. This contracts muscles in the upper intestine, causing faster emptying of the stomach, and it can increase peristalsis in the bowel and will add to emptying the bowels a little bit quicker. That is all I have for you for the GI unit. I hope you get some beneficial information out of this. Make sure you read your text, reach out with questions, and I am here to help in any way that I can. Don't forget to do your guided reading also. You guys take care. Have a good day.